Welcome to Acute Kidney Injury and Chronic Kidney Disease by Donna Fessler. Welcome to Acute Kidney Injury and Chronic Kidney Disease. Okay, so let's compare acute kidney injury with chronic kidney disease. In acute kidney injury, you have a rapid onset, and then with chronic, it's gradual. It usually will progress over years. Some of the common causes for AKI is acute tubular necrosis, so not enough flow. The tubules become ischemic, and then they become necrotic. And then in CKD, you've got the diabetic nephropathy that occurs, just that constant damage from uncontrolled blood sugars. The diagnostic criteria for AKI is acute drop in urine output. So we're looking at that urine output that's 0.5 mils per kilogram or less. Then with your chronic kidney disease, they will have a glomerular filtration rate of less than 60 mils, and or kidney damage that's older than 3 months. So it just shows that that's reached its irreversible state. The mortality for AKI is about 60% of patients that go into that will die. And then for chronic kidney disease, it's 19 to 24%, and that's because those are on dialysis. The cause of death for AKI is infection. Usually that's the reason why they go into AKI. Sepsis is a real big one. And then chronic kidney disease, you end up with cardiovascular disease that ends up killing them. It can be carotid plaque. It can be embolic, strokes, pulmonary emboli, heart disease, so forth and so on. Acute kidney injury is reversible. It's potentially reversible. Again, it's early detection, early treatment provides the best outcomes. And then with chronic kidney disease, it's progressive and it is not reversible because, again, that damage is permanent. And then for the sake of Lewis, they define kidney failure or acute kidney injury as being partial or complete impairment of kidney function. Usually results in the inability of the kidneys to actually excrete metabolic waste products and water. It also contributes to the disturbances of all body systems. So again, it can be classified as acute kidney injury or chronic kidney disease. Acute's rapid, chronic is progressive, usually takes months to years before it's noticed. And fairly significant kidney damage or kidney disease is present before actual renal or hemodialysis is required. They try to manage them medically as long as they can. So Lewis defines acute kidney injury being basically to cover all the ranges of damage that can occur to bring on the acute kidney injury. Again, you have a rapid loss of kidney function, which is usually demonstrated first by a drop in urine output. Secondly, you'll see a rise in the serum creatinine or a rise in the BUN. a lot of times the severity of that particular dysfunction will be that rise in the BUN and creatinine, and they call that azotemia. And that just means there's, again, that collection of nitrogenous waste products circulating in the blood. And it's usually severe enough to actually warrant renal replacement therapy. And like I said before, it's usually that continuous renal replacement therapy, also known as SLED, which stands for slow, low efficiency dialysis. And that's just because they don't have the volume needed to help support that blood pressure. So even taking a cup of blood away from them, it will be too much in their acute state. And then, like I was saying on the previous slide, is that it is or can be reversible if it's caught early enough, but it does have a high mortality rate. And that's mostly because the clients have some other life-threatening conditions, usually sepsis. So they go into sepsis, they get their blood cultures, they get tons of fluid, they've already had low blood pressure, and it's going to stay low. And then a lot of times the antibiotics they start can be nephrotoxic, so you have the double whammy there, the low flow and the nephrotoxic agents. Again, it'll usually develop over hours. It can start occurring while the patient's having their major surgery, and it doesn't go and it goes unnoticed until that urine output is less than 30 mils per hour, which for a normal size American, that's quite low and unacceptable for that patient's size. The causes, again, are multiple. Discussed before, pre-renal, intrarenal, and post-renal. Pre-renal has to do with that flow going through the glomerulus capillary bed there. Intrarenal has to do with any injury that has occurred directly to the kidney tissue, so the nephron itself, and results in impaired function of that nephron. That can usually occur from prolonged ischemia, which turns into the necrosis. From the nephrotoxins, like I said, antibodies, contrast media. You can have the hemolyzed red blood cells, the hemoglobins are released from that, or you can get the myoglobins that can be released from necrotic muscle cells. And remember that can stem from anything that causes the rhabdomyolysis. So rickettsial disease or, statins. Once they do go into the acute tubular necrosis, again, that is the most common cause of intrarenal AKI. And that just stems from pre-renal that leads into a renal issue if it has to do with low flow. Otherwise, it's caused by nephrotoxic agents. 90% of that intrarenal acute kidney injury occurs from the acute tubular necrosis. So as the tubules die, they start sloughing off. Those cells slough off, plug the distal ends of those tubules, and it can be reversed if the glomerular basement and membrane is not destroyed, and if the tubular epithelium can regenerate. That urine is going to look, again, murky, muddy, brownish, so just kind of keep that in mind. Your post-renal, of course, is anything that obstructs that outflow of urine from the renal pelvis. It can be obstructed, partially obstructed. It can be something that causes urine reflux into the renal pelvis. All in all, it will cause impaired kidney function, and usually will have a hydronephrosis issue. You can see a picture of that in your book in chapter 47. It's the first picture in that chapter. So hydronephrosis, we say water on the kidney, but it's basically those kidneys are dilated out, backed up with liquid and waste products. That increase in the hydrostatic pressure itself is what causes the tubular blockage, and that will cause progressive decline in the patient's actual kidney function. So if someone has 2 kidneys and they're fairly healthy, then it's not going to show up on the lab work. And as long as your obstruction is relieved within 48 hours of onset, then more than likely you're going to have a complete recovery of your glomerular filtration rate. If it goes untreated for 12 weeks or longer, then of course probably is irreversible at that point in time. Prolonged obstruction can in turn lead to the tubular atrophy, and that is irreversible. You do have a table in chapter 47. It's table 47. 2 goes into the common causes of acute kidney injury. Again, prerenal usually has to do with hypovolemia, which is secondary to dehydration, hemorrhage, GI losses, excessive diuresis, your hypoalbuminemia, and burns. It can be from decreased cardiac output, can be secondary to cardiac dysrhythmias, cardiogenic shock, heart failure, myocardial infarction, decreased peripheral vascular resistance, usually related to anaphylaxis or neurologic injury. Septic shock will also have that effect on the vascular system. And then, just in general, decreased renal vascular blood flow. So, you might get bilateral renal vein thrombus. You can get arterial embolisms, or even venous embolisms. If they are in hepatorenal syndrome, then they will have issues as well. And then I said that the arterial system can become clotted off as well. For your intrarenal, that is nephrotoxic injury. You're looking at drugs, your aminoglycosides such as gentamicin, amikacin, amphotericin B, your radiocontrast agents, hemolytic blood transfusion reactions, a severe crush injury. There are some chemical exposures that can cause it, such as ethylene glycol, which is your radiator fluid, your dogs love that stuff, I guess. Lead, arsenic, carbon, tetrachloride. So look for the following continuation of this, and eventually we will get through chapter 47. So also for intrarenal acute kidney injuries, you've got drug-related allergies that can cause it. Your NSAIDs are a big culprit. Your ACE inhibitors. We talked about how the ACE inhibitors can actually cause vasoconstriction in the efferent or exiting arteriole from the glomerulus, and which slows flow through the glomerulus and increases reabsorption of items that are usually reabsorbed. Infections such as bacterial, your acute pyelonephritis, your viral cytomegalovirus, fungal, candidiasis. Other causes can be, of course, your prolonged prerenal ischemia, acute glomerulonephritis, which we talked about, that was a streptococcal infection, usually related to untreated strep. Thrombotic disorders that can clot off the tubules, toxemia from pregnancy. You can have malignant hypertension. That is a very interesting process. It is hereditary. What occurs is if you receive the neuromuscular blocking agent, succinylcholine, and usually in combination with your gas for general anesthesia, it can cause muscle contraction that does not relax. So that puts the patient into a severe hypermetabolic state. The only thing that can rescue them is a drug called dantrolene, and we actually will call a code dantrolene. And it usually occurs while they're still on the operating table, but not always. It can occur, they've seen it occur up to 24 hours after receiving those agents. It is very similar to neuroleptic malignant syndrome as well, and that is a common drug reaction to medications such as Reglan and Phenergan. So when you see that, then you kind of have an idea what that is. This person, their body temperature just shoots at the roof. They go into the rhabdomyolysis as well, myelitis. So that's the reason why it will go into the kidney. So anyway, they will die if intervention's not done, because the hypertension that they get is extremely high, like 300 over 150 on that kind of blood pressure. And then your systemic lupus erythematosus, and that just causes sclerosis of all of your internal organs. If you have the scleroderma type, it just depends on the type that you have, but it will also cause thrombotic disorders, and they usually have to be on Coumadin for that. Post-renal, again, is anything that slows or blocks the flow of urine out of the renal pelvis. It's the biggest cause is the benign prostatic hypertrophy or hyperplasia. You get bladder cancer, prostate cancer, bladder stones, renal stones. If you're older, then it can cause problems if you have two kidneys that are blocked. If you're older, much older, and one kidney is blocked, it can be significant. But usually in the younger population, they can handle that. It's just the pain that is excruciating. Some neuromuscular disorders that prevent emptying of the bladder, such as neurogenic bladder, prostate cancer, I said that, spinal cord disease, strictures, trauma. So, no matter what the cause of the AKI, you will usually, patient will usually progress through the phases of oliguria, diuretic, and recovery. And again, like I said, sometimes patients don't recover from acute kidney injury. They end up with chronic kidney disease, and eventually, depending on the cause of the injury, they may require dialysis or a kidney transplant. If you look at the article that I referenced in the PowerPoint and the one I used in class, they had a pop out on that article about rifle, and the classifications that's used to describe the stages of acute kidney injury is just to standardize the diagnosis of AKI. So R is for risk, and that's your first stage of AKI, followed by injury, which is the second stage, and then increasing severity to the final or third stage of failure. The other two outcome variables are loss and E for end-stage kidney disease. They have dropped the L and the E off of it, so now it's just RIF when you read that in that journal article. So when we're talking about risk, that for the criteria on the risk stage, you have a serum creatinine that has risen 1.5 times baseline, or the GFR has decreased by 25%, and your serum creatinine has increased double. Your urine output will be less than 0.5 mils per kilogram per hour for 6 hours. And many times it will drop off even more after that. Remember that we base that on what the average size, so what would be the highest normal weight for that person with a large frame of that height. Because remember, fat cells don't have a lot of water in them. So they're not going to require a lot of water for energy breakdown. So that's the reason why I say don't calculate their actual weight, but the weight that they probably should weigh for their height. So if you go to actual injury, then the GFR is going to be decreased by 50%, and the serum creatinine will be increased times 3. Your urine output, again, is going to be less than 0.5 mils per kilogram per hour for a total of 12 hours. Then for actual failure, the GFR is decreased by 75%. The serum creatinine is greater than 4 milligrams per deciliter, with an acute rise of more than 0.5 milligrams per deciliter. Patient will probably be oliguric with a urine output of less than 0.3 mils per kilogram per hour for 24 hours, and or there will be anuria, absence of urine, which for about 12 hours time. So usually only about half of the patients with acute kidney injury will have oliguria. The GFR and the urine output don't always correlate, but noticing the actual severe changes in that urine output can be the most important thing, because it will help you differentiate between the types of AKI. So if all of a sudden they develop anuria, so they have no urine output, that usually points to some type of urine tract obstruction. Your oliguria is most commonly seen, of course, with your pre-renal etiology, so of a flow issue. And then what they call non-oliguric AKI is more with actual damage to the nephron, so your acute interstitial nephritis and acute tubular necrosis. The urine, you may have CAS, red blood cells, white blood cells, specific gravity fixed at around 1010, and that urine osmo around 300. The casts are formed from that mucoprotein. Impressions of the necrotic renal tubular epithelial cells, and those are the ones that have detached and sloughed into those tubules. So it's usually about the same as whatever the specific gravity and the osmo is for the plasma, which does help reflect the tubular damage and the loss of the kidney's ability to concentrate. So this is more of your intrarenal, because you're actually reabsorbing with pre-renal, you're absorbing your water and sodium, so it is concentrating. Proteinuria may be present if there's damage to the actual glomerular membrane. So remember I said it can let larger molecules through and you can lose a lot of protein that way. You can get the metabolic acidosis when you have actual kidney failure. The kidneys cannot synthesize ammonia. Now, that is needed for the hydrogen ion excretions. So, some ammonia is secreted into the renal system, kind of like creatinine is. So, whenever that is blocked, then it has issues with being secreted and therefore being not present in the renal system for the kidneys to use in control of the acidosis. And I think I just said that you have defective reabsorption and regeneration of that bicarb. When the patient does go into severe acidosis, they'll develop those Kussmaul respirations, be rapid, deep respirations, trying to blow off that carbon dioxide to get rid of that type of acid. Your sodium balance will be off kilter. So, depending on if it's pre-renal or intrarenal, the urinary excretion sodium may increase, and we all know that's from renal or intrarenal. It decreases whenever it's pre-renal because it gets reabsorbed because of the slow flow. So you make sure that if it is renal, that excessive intake of sodium needs to be avoided because we don't want them to continue to reabsorb water and sodium, which will lead to volume expansion. They get the hypertension, they can go into heart failure because of fluid volume overload, and the uncontrolled hyponatremia or water excess, again, can lead to seizures secondary to cerebral edema. We don't want the patients to get potassium excess, and I'll talk about that in the next podcast and go into more details on that, what it'll look like on the monitor as well. So note the urine droplets on the right side of the screen. So if you were to see urine like this, what might that indicate? So just kind of keep in mind, it's not necessarily the color of the urine that we're looking at. That is important for certain things. But when you see a certain colored urine, then you want to see what medications the patient's been receiving, just to kind of know, hey, that's probably from the medication. Pyridium usually will turn the urine a bright orange, but if they are a little dehydrated and the urine is concentrated, then it'll be a brownish orange, like a really dark amber. And then macrodantin, antibiotic for chronic kidney infections or chronic bladder infections usually, can also turn their urine a brown color. And again, it gets that darker brown if it's concentrated. So there are several reasons of chronic renal failure. Again, a lot of those are related to failure to recognize and treat acute kidney injury in a timely manner. Those can be changes in the glomerulus, such as glomerulonephritis, basement membrane disease, Goodpasture syndrome, intercapillary glomerulosclerosis. Tubular disease would include chronic hypercalcemia, chronic potassium depletion, Fanconi syndrome, and heavy metal poisoning such as lead. Vascular diseases of the kidney, specifically ischemic disease of the kidney, bilateral renal artery stenosis, nephrosclerosis, hyperparathyroidism. You have the urinary tract disease, which would be the obstructive uropathy, and that's usually related to untreated prostate enlargement, whether it be benign and or cancerous. You've got inherited or genetic conditions such as hypoplastic kidneys, medullary cystic disease, polycystic kidney disease. Infection, usually pyelonephritis or tuberculosis. Systemic vascular disease would include intrarenal renovascular hypertension and extrarenal renovascular hypertension. Metabolic renal disease includes amyloidosis, gout, which basically is your hyperuricemic nephropathy, diabetic nephropathy, milk alkali syndrome, sarcoidosis, and then you have some connective tissue diseases such as progressive systemic sclerosis, systemic lupus erythematosus, and the polyarteritis. I don't know, I can't say it. So the way that kidney failure actually causes bone disease, whenever the GFR, glomerular filtration rate, is decreased, it leads to decreased excretion of phosphate. Decreased excretion of phosphate leads to, of course, increased serum phosphate. This leads to metastatic calcifications. That doesn't mean cancer, it's just the calcifications occur because of the increased serum phosphate. On the other spectrum, the way it affects the actual activation process for bone growth to occur, or the normal repair process, is altered because the renal failure causes a decreased activation of vitamin D, which in turn causes an impaired calcium absorption from the gut, because we need vitamin D in the gut in order to absorb calcium correctly. So, of course, decreased absorption of calcium leads to decreased serum calcium, which will stimulate the parathyroid hormone, the parathyroid gland, which in turn will cause osteitis fibrosa, which the increase in the PTH will cause bone demineralization, and that leads to the osteomalacia, which is basically softening of the bones. So it's kind of that whole osteopenia, the osteoporosis process that occurs. So when the bone demineralizes, then all of a sudden you have an increase in serum calcium and an increase in phosphate. And again, that can lead to the metastatic calcifications. So we'll go over it this way. It's basically the same information, but I'll word it differently. So renal failure affects on phosphate. So we'll go to the left. Causes phosphate retention. That will be hyperphosphatemia. So your phosphate level will be elevated in the blood. That's where it's being retained. What happens is that will bind, the phosphate will bind with your calcium, because phosphate is a negatively charged ion. So when that binds with your calcium, that will cause a decrease in your serum calcium. That will cause release of parathyroid hormone by the parathyroid glands. Okay, so on the same spectrum, the effect of calcium on the right-hand side, renal failure will affect calcium in this manner, is the decreased production of active vitamin D, which leads to a decreased absorption of calcium from the GI tract, which leads to decreased serum calcium, which will also stimulate the release of the parathyroid hormone by the parathyroid glands, which will cause calcium to be released from the bones where it's being stored. This is called the bone demineralization, and this causes bone density loss. So the bones become soft. This will increase the serum calcium, and then you will have further binding of phosphate with the calcium. So it's that chronic demineralization, the binding of calcium. The body needs calcium because the phosphate has been binding, the raised phosphate level has been binding with the calcium in the blood. So it lowers the calcium. And then the bone breaks down, releasing the calcium into the blood. And that, in the meantime, the phosphate has raised again, and it'll bind with that calcium again. So it's just a repeated cycle, constantly breaking down the bone by those endocrine processes. So these patients have to be on a phosphate binder that is given with the meals so that the patient can hopefully absorb the calcium that they ingest. So let's talk about that endocrine system and how it affects the body. So we'll talk about renal hormone production. Number one, of course, is the renin. And that comes from renin-producing granular cells. Renin raises the blood pressure as a result of the angiotensin. That angiotensin causes the local vasoconstriction, which is the process of is how it raises the blood pressure. And then the aldosterone, and then secretion. The aldosterone will help be a volume expansion. It's a result on the vascular system. Another renal hormone is your prostaglandins, and those are released by the renal tissues. And that will regulate that intrarenal blood flow, and by causing either vasodilatation or vasodilation, however you want to say it, or vasoconstriction. Another one is your bradykinins, and that works at the juxtaglomerular cells of the arterioles. And what it does is it causes an increased blood flow, so the vasodilation, and then vascular permeability. So it increases that permeability, so it kind of lets things flow out to adjust for that pressure. Then we talked about the erythropoietin. Now that is comes from the renal parenchyma, and that stimulates the bone marrow to make more red blood cells. So that is kind of reduced in those people that have renal failure, so therefore they have to get a synthetic version. Now they can become resistant to synthetic erythropoietin, and they have other things to treat the anemia at that point, but we won't go into that. And then activated vitamin D. So that again comes from the renal parenchyma, and that promotes that absorption of calcium in the GI tract. So again, in renal disease, you don't have enough of that activated vitamin D. Now, the hormones that actually influence the renal function itself is the antidiuretic hormone, so ADH, vasopressin, putrescin. Like I say, that's the best way to remember it, is putrescin and pitocin come from the posterior pituitary, so the P's. So that makes your distal convoluted tubule more permeable to water to help maximize that reabsorption and produce a more concentrated urine whenever it's stimulated. Your aldosterone, we kind of already talked about that. That's released from your adrenal cortex, and that will promote your sodium reabsorption and potassium secretion in that distal convoluted tubule. And as you know, water and chloride always follow sodium movement. And then your natriuretic hormones, those are from the cardiac atria and the brain. And what that does, it causes the tubular secretion of sodium. So let's talk about some of the medications that are used in patients with chronic kidney disease. And some of these are based on pre-existing disease conditions. Digoxin, the usual dose, of course, of that is 0.125 to 0.25. That can be milligrams by mouth or IV, and that can be done daily or every other day. For your older adults, it's going to be closer to 0.0625 to 0.125 by mouth or IV every other day. Now remember, because they just don't have as many nephrons, so in your older adults, they won't need as large a dose. So the reason why you would give that, of course, is because you have a decreased stroke volume, which is caused by that decreased strength of your cardiac contractions. Your nursing interventions for digoxin are you're going to monitor for those signs and symptoms of digoxin toxicity and hypokalemia. You want to monitor for bradyarrhythmias, so basically pulses that are less than 50 to 60 beats per minute, apical, and monitor your serum drug levels as prescribed. Now, you want to remember that digoxin remains in the body a lot longer when the renal function is impaired. So you may have someone that comes in acute kidney injury, and they take digoxin, and they're coming in third-degree heart block. That's because all of a sudden you've got a buildup of that digoxin because it's not being excreted as it should. Again, bradycardia is a sign of that digoxin toxicity, and a toxic level of digoxin, of course, is greater than 2.5 nanograms per milliliter. So as that acute kidney injury might resolve, but we're talking about chronic kidney disease, but just kind of going back to that acute kidney injury, when that resolves, remember that dose of digoxin that they've been therapeutic on for the past week is now going to drop. So just kind of keep that in mind when you're thinking about digoxin. Now, they'll probably on some vitamins and minerals. They're usually just on a multivitamin that has iron in it, but they may be on separate, like folic acid, and the usual dose of that is at like 0.1 milligrams PO. I haven't really seen it given sub-Q or IM. And basically it's a dietary supplement given after dialysis. It is one of the water-soluble vitamins that gets removed during dialysis itself. Iron, of course, 325 milligrams by mouth, usually 3 or 4 times a day, and that's to help with anemia. We want to make sure the patient doesn't become constipated. Stools are going to become kind of a sticky, blackish green. They really have to be on stool softeners. especially with chronic kidney disease, because they are on a fluid restriction, so we want more of that water to stay in the GI system. And stool softeners helps with that process. Constipation becomes very uncomfortable. It's going to affect their appetite, and we really need them to stay nutritionally balanced. And there's a lot of iron. A lot of that iron goes to the GI system unabsorbed, so that's the reason why the black stools. Now, if there's blood in the stool, it's going to have that odor to it. It's going to change in odor, not necessarily color. So your biological response modifier is erythropoietin, Epigen, Procrit, EPO. Those are the names for it. Usual dosage is 50 to 100 units per kilogram, IV or sub-Q 3 times a week. I've always given it sub-Q. I've never been real excited about giving it IV. More likely going to have that heart failure, pulmonary edema response from the IV dose. And we're giving that for that anemia that's associated with the chronic kidney disease. You're going to monitor the patient's hematocrit twice a week in the beginning until they can transition to more of a therapeutic dose. Monitor the blood pressure, because they can, with a rapid rise in the hematocrit, it will cause hypertension. The dose really is based on the response, and it has to be measured by those changes in the hematocrit. And once it becomes level, then they will usually change the check of the hematocrit, usually to weekly, and then eventually just monthly. That is a very expensive drug. The newer drugs for those that are erythropoietin resistant are even more expensive, so kind of keep that in mind. Now, again, we talked about the phosphate and calcium issues, so these patients need to be on the phosphate binders. The aluminum hydroxide is your Amphigel, Alternagel, and then you may have them on a aluminum carbonate gel, also known as Basagel. That's 500 milligrams to 2 grams by mouth, twice to 4 times daily. There may be tablets, capsules, or an oral suspension, and these are to bind with the phosphate to help prevent that bone disease. You'll hear it called renal osteodystrophy. We're going to monitor for constipation. Again, does occur frequently. We want to monitor for the signs of low phosphate, so hypophosphatemia. Constipation, again, it's that frequent side effect, and the drugs can prevent intestinal absorption of the phosphorus, which in turn will help prevent binding of that calcium, but it can also lead to the hypophosphatemia. Renagel, you'll see that tends to be a little bit more popular. That's the sevelamer hydrochloride, and that's usually given that if the serum phosphorus level it's given based on the range of the phosphorus level. So if it's 6 to 7.5 milligrams per deciliter, then 2 capsules 3 times a day is indicated, and as the level goes up higher, so does the dose, and that's for that hyperphosphatemia. We're going to give that with meals because we want it to bind with that phosphorus in the food. We want to prevent the absorption of that phosphorus. I'm going to tell the client be sure and swallow the capsules whole, not to chew them. The drug tends to expand when the capsules are broken, so if a patient had like a hiatal hernia or something to that effect, it could cause some problems. I'm going to monitor those serum phosphorus levels. Again, the drug can cause hypophosphatemia. Calcium carbonate, they usually need some calcium supplements, and A lot of times it'll just be Tums, Oscal, Calcichews, and that's usually 1 to 3 tablets by mouth throughout the day, basically to help bind that phosphorus as well. You want to only give when the serum phosphate levels are normal. I want to monitor for high calcium, which usually doesn't occur. I want to prevent constipation. They can also get soft tissue calcifications, and this is given after meals. We want the calcium supplements can cause a decrease in the serum phosphate levels because the two minerals exist in the blood in a balanced reciprocal relationship. Giving binders after meals enhances that binding capacity. So know that if your patient's on it as a supplement to raise their calcium level, or if they're on it for binding the phosphate. Very important to be looking at those numbers on your labs. Stool softeners and laxative. Usually Colace is like the one of choice. It's 100-300 milligrams daily, and we want to prevent the constipation that's caused by that limited fluid intake, the iron and the phosphate binders and the calcium. Want to observe for any abdominal cramps or diarrhea. Monitor those bowel movements. And again, the GI effects, if they're having abdominal cramps and diarrhea, it usually means that they're getting too much of the medication. Now, the doctor may also order Dulcolax, and this is can be given as a pill or as a suppository that's given daily or every other day. And again, that's more of a stimulant to stimulate an actual bowel movement. And I think that's all on medications at this point. Okay, so much is to do about the diet with chronic kidney disease. So let's talk about the nutritional therapy. Fluid, again, we want to do urine output. What was the urine output and from the previous 24 hours? And then you add 600 mils to that for the next 24 hours. And they base hemodialysis on that as well. Peritoneal dialysis, they usually don't have any fluid restrictions, so you want to kind of keep that in mind. Depending on what their other chemistries are showing, you would base what kind of fluid allowance that would be. So if their sodium levels are low, then you might want to make their intake more of non-water, no free water type thing. Protein, usually they need, for conservative management, you're going to do 0.6 to 0.75 grams per kilogram per body weight. For patients that are on hemodialysis, they'll probably be on like a 12 to 13 grams per kilogram of ideal body weight. And yeah, that's a pretty good dose of protein. But remember, a lot of times they're losing a lot of proteins, especially the albumin, through that glomerular basement membrane. It's become damaged and more porous. Peritoneal dialysis, usually they want them on 12 to 13 grams per kilogram or more of ideal body weight. Calories, the same across the line. We want 30 to 35 calories per kilogram based on their ideal body weight on your peritoneal dialysis, whereas with your conservative and hemodialysis patients, you want it based on their daily weight. Fat, you're going to determine based on the caloric requirement for conservative management. Same thing for hemodialysis, same thing for peritoneal dialysis. Carbohydrates, pretty much on conservative management. If they're not diabetic, it'll be unlimited intake of sugar, starches, bread cereal products may be limited based on the fact that there are some proteins in your grains. So if they're on a protein restriction, then of course that may be limited. Same thing for hemodialysis, and then basically peritoneal dialysis carbohydrates are dependent on the individual patient's needs. Iron is variable based on need. Potassium with your conservative and hemodialysis patients is going to be 2 to 3 grams per day. On your peritoneal dialysis, they may have no restrictions, or they may be restricted 3 to 4 grams per day. Sodium is 2 to 3 grams on your renal patients. Phosphorus is 800 to 1,000 milligrams per day on your conservative. On your hemodialysis, 1,000 milligrams. Peritoneal dialysis is 1,000 milligrams. Calcium is variable on your conservative hemodialysis, that we want to make sure they get 1,000 to 15 milligrams per day. Same thing on the peritoneal dialysis. Folic acid, looking at 1 milligram supplementation daily on all of those. So there's different types of vascular access so that the patient can have hemodialysis. They may have 2 of these, or so they may have more than one access at any given point. So an AV fistula, basically that is when the surgeon goes in and will open up the side of a vein and open up a side of an artery and sew that together. So that's the reason why you get that rough sensation, which is called a thrill. So remember, you feel the thrill and you hear the bruise. So if you put your stethoscope in it, you'll hear that swish, 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 rough sounding flow in an AV fistula. Those are usually in the forearm, but they can be in other places. You don't want to use that arm for anything else. When those are new, it can take 2 to 4 months or longer before they're used the first time. So you'll hear that it's not cured yet, it's not ripe yet, so that's what they're talking about. It's not ready for use. An AV graft is similar but different because they do use a synthetic vessel type tubing, and they tunnel that beneath the skin, and those connect a vein and an artery. So same concept, it's just maybe that they're going to need to use it a lot quicker, or their veins and artery walls are not super strong, and they've had failed fistulas in the past, so they're going with the graft this time. In the interim, they may have the dual lumen hemodialysis catheter that could be in the groin, it can be in the neck, it can be in the subclavian area as well. Now the AV graft, going back to that, it may be in the forearm, it may be in the upper arm, and it may even be in that inner thigh. So just kind of keep that in mind when you're assessing your patient. So the dual lumen hemodialysis catheter, again, that's an extended use catheter. It's surgically tunneled underneath the skin and has a barrier cuff. They usually use the subclavian vein for that one unless it's going to be temporary. And if it's temporary, it's not tunneled. Anyway, after the tunneled one is placed, it can be used immediately after it's confirmed by x-ray. So the temporary, the hemodialysis catheter, may have the dual, there may even be a triple lumen. Now these are special designed. The 2 lumens are for blood outflow and inflow for hemodialysis. The 3rd lumen does allow for venous access without actually accessing those dialysis lumens. So a patient with that's going to be needing some IV therapy as well may have one of these, the triple lumen. Again, those can be placed in the subclavian, the internal jugular, or the femoral vein and it is not tunneled. Those can be used immediately after insertion, after it's confirmed by X-ray placement. Now, these are filled with high-dose heparin just because they're large bore, so blood can back up into them and clot them off. So it's not uncommon for those to be filled with a 15,000 unit per mil solution. The reason why we don't access those, or if you should access those, you always aspirate first to pull that heparin out, and then you do not put that heparin back in, you discard that syringe, then you do your saline flush, and then whatever is ordered. And the only time you would use that is if there's no other access, and you must have a physician's order, and you must do that correctly. Now, an AV shunt, this is relatively uncommon. It is, and I have never seen it in my 20-some-odd years of practice, an external loop of celastic tubing that connects to an artery and a vein. Each section of that tubing is sutured into the vessel itself, whether it be an artery or a vein, and it is brought through the skin with from an actual, they call it a stab wound, but anyway, an incision. And it's usually placed in the forearm, and they can use it immediately after insertion. Another thing I haven't ever seen is a subcutaneous device, and that's basically an internal device. It has 2 metallic access ports and 2 catheters that are inserted into large central veins, so there's no artery involved. And this would be probably someone that may be going home, that has had failures of the fistulas, and they're at high risk of infection, so they don't want to leave anything that would be hanging outside of the skin. So it's based on the concept of like the portacaths, where they have the disc underneath and you can access them with a Huber needle. It's that same kind of concept, and same location, subclavian vein, and it can be used immediately after insertion. But again, I've never seen those. I don't know if they're relatively new, but they are considered temporary. And dialysis, hemodialysis in general, depends, again, like I said, on what they're getting it for. Patients really have to have the hemodialysis in order to keep their potassium down, because otherwise, you know, it's going to lead to lethal arrhythmias and death. So at some point, your patient may have to have hemodialysis. And education for those patients, especially that are new to it, has to be very clear, very concise, so that they understand the importance of it. So there's certain things that you need to consider when it comes to the patient that has access for hemodialysis. Again, we're not going to do any blood pressure readings or use that extremity at all for vascular access, whether it be a dialysis catheter, an AV fistula, an AV shunt, or any of those. If there's anything in that extremity for dialysis, you don't use it. Again, no venipunctures or IV lines to that extremity. You're going to palpate for the thrills, so feel the thrills, and you're going to listen for the bruit every 4 hours while that client is awake. And those are more for the new ones. And then whenever your patient returns from dialysis, your initial daily assessment. So anytime there's a change or when it's been accessed, and just your routine assessment, you're going to feel the thrill and hear the bruit in that patient. So now below that site, again, you can get clots in that AV fistula or AV shunt. So you want to make sure that those distal pulses in circulation are adequate. You've got venous arterial mixing going on, so they're at high risk of developing thrombi in that area. Kind of just kind of keep that in mind and always be looking and assessing for that. That arm, after it's been placed, after the AV fistula or AV shunt has been placed, you're going to keep that elevated, heart level or higher, usually just propping it up on pillows. If for some reason, if it's anywhere near that antecubital space or below that antecubital space, you want to prevent them from bending that arm as much, because it decreases that flow and puts them at higher risk of developing thrombus. Encourage range of motion to that extremity. Going to check for bleeding at those needle insertion sites, whether it was a shunt or a fistula. They usually come back with just a gauze dressing and tape to that site. You just want to make sure that they don't get any bleeding. A lot of times it's not external bleeding, it's internal, so you want to be assessing that site for a hematoma as well. You're going to instruct the client not to really use that arm for anything heavy, any heavy lifting, or anything that's going to put some compression or restriction on that extremity. So like if they're carrying groceries, they wouldn't want to carry anything heavy. If they're carrying a purse, they want to make sure they're not carrying it on that side or where the arm straps would actually occlude flow. Going to instruct the client that against sleeping with his or her body weight on top of that extremity that the vascular access is actually placed in. So let's talk about patient and family education for your chronic kidney disease. You want to make sure that they really understand their dietary order and the fluid restrictions. Make them responsible. Make sure they repeat the information back to you. Make sure you put the information in simple language. Again, they recommend 4th to 5th grade reading level for information. You want to encourage discussion of any difficulties that they're having in modifying their diet or fluid intake. Hopefully, those will be recognized during the hospitalization, but not always. This may be a patient that you're receiving in the home health setting, so you want to explain any signs or symptoms of electrolyte imbalances, especially the high potassium. You're going to teach alternative ways of actually reducing thirst, such as sucking on ice cubes, lemon or hard candies. You want to explain the rationale behind just about everything you're teaching them. Patients are more likely to follow instructions if they know the why. So especially with the medications, those common side effects. So like phosphate binders always should be taken with meals. The iron supplements should be taken between the meals. The phosphate binders can decrease the absorption of iron. Tea, something simple as tea, can inhibit the absorption of iron when ingested 2 hours before or after the iron. So we want to keep that in mind as well. Vitamin C enhances the absorption of iron. You want to be sure and explain the importance of reporting anything in the following: a weight gain that's more than 2 kilograms, which is 4 pounds, an increasing blood pressure, increasing shortness of breath, increasing edema or development of edema if they haven't had edema, development of shortness of breath if they haven't had it. If they're having problems with increased fatigue or weakness, and remember that can have a lot to do with the high potassium. If they're having any confusion or lethargy, again, that can be a higher, the uremic acids are building up, or those toxins are building up, can be a low sodium, so those things are important. You want to encourage the patient and the family to share any type of concerns they have about lifestyle changes, the best way to manage and live with a chronic illness, decisions on what kind of dialysis, or maybe that they're on a transplant waiting list. We want to be sure that they talk about these things so that we know where they're at and what's going on with them. Having chronic kidney disease can be quite expensive, but it is also very cumbersome, especially for The younger you are or the older you are, the more dependent you are on others to help you with the process. Transplant is more common nowadays than it used to. They'd always use a live donor, knowing compatibilities could be issues. These patients have to be on medications to help prevent rejection of the organ. They will be on monoclonal antibodies that helps remove circulating T lymphocytes. You want to administer prescribed Tylenol, diphenhydramine, and hydrocortisone at the time of the IV infusion. They may be on monoclonal antibody that's against the IL-2 receptor, and with them, they're going to definitely monitor the daily weight and lung sounds, GI status, looking for GI issues of nausea, vomiting, diarrhea, INO, and temperature. The monoclonal antibodies also will block those T cell activation and proliferation. Some of these things I can't even pronounce. So they may be on chimeric anti-IL-2 receptor antibody. One of the names for that is Simulect. And they may be on the diclaximab, which is a humanized anti-TAC Xenopax, are some of the names for that. You may have an anti-lymphocyte globulin or an anti-thymocyte globulin. The polyclonal antibodies are directed against the lymphocytes. It reduces circulating lymphocytes and can decrease the lymphocyte proliferation. In these patients, you want to monitor for peripheral edema, complaints of a headache, photophobia. You want to monitor the platelet count, report if it is trending down rapidly or if it is less than 100,000. You want to administer any prescribed diuretics. You want to arrange for their outpatient infusions to help complete the course of the therapy after the discharge from the hospital. They may be on purine synthesis inhibitor. This inhibits the purine synthesis. They may be, I'm just going to call it Cellcept, is one of those that fall under that classification. That does help suppress the T cytotoxic lymphocyte proliferation. Again, monitor daily weight, GI status. If they're having issues with nausea, vomiting, diarrhea, abdominal cramping, or dyspepsia, you want to keep up with their INO and their white blood cell count. You're going to administer any antiemetics and antidiarrheals as prescribed. So patients that are on immunosuppressive agents are at high risk of becoming infected just from fresh fruits and vegetables or even plants. You're going to make sure that you put them in protective isolation. Neutropenic isolation is the other name for it. You're going to constantly be assessing for signs and symptoms of infection. You want to inspect their oral mucosa membranes because they're at high risk of developing thrush, yeast infections. They want to maintain good oral hygiene, include the flossing. Going to be monitoring for drug side effects. And they need to wear a mask anytime they're going to be outside of the room. And if anyone's ill or has been vaccinated with live virus, they need to stay away from the patient. Or if they live in the same household and it's not preventable, then they need to wear masks. So your calcineurin inhibitors are your cyclosporin. You may also hear it called Sandimmune or Neurol. and that inhibits the T cell interleukin 2 protein, inhibits maturation of the T cytotoxic lymphocyte precursors. You're going to monitor for drug side effects, which can be acute and chronic nephrotoxicity, hypertension, dyslipidemia, and you're going to monitor the trough concentrations, their serum creatinine, their BUN, potassium, liver enzymes, and coagulation factors. I know it's nephrotoxic, but many times it takes a good 10 years before it actually will kill off the nephrons. Tacrolimus, also known as Prograf, helps prevent production and release of interleukin 2, inhibits maturation of T cytotoxic lymphocyte precursors of cyclosporin. You're going to monitor for edema, hypertension, jaundice, neurologic status, especially noting tremors, paresthesias, headaches, confusions, and seizures. You're going to monitor GI status, such as anorexia, nausea, vomiting, diarrhea, and weight loss. On sirolimus, the names for the other names is rapamycin or rapamune, and this suppresses the lymphocyte proliferation, inhibits B cells from synthesizing antibody. Monitor daily weight, INO, blood glucose. You're going to teach the patient. Side effects, they're usually being based on dose, use of a depilatory if they do develop facial hair growth in women. You definitely need to do their dental cleaning every 6 months, and especially if gingival hyperplasia develops. They may be told to decrease their dose or increase their dose, so it can be a constant flux for them based on their lab results. Going to administer diuretics and hypertensive agents as they're prescribed. We're going to monitor the blood glucose levels, administer prescribed insulin or oral hypoglycemic agents, and it's usually, the sirolimus is usually administered over central line over 46 hours. Antiproliferative agents would be your Imuran. That suppresses proliferation of rapidly dividing cells, including sensitized B and T cells. Alkylating agents such as cytoxin interferes with the DNA, RNA, and protein synthesis. So for these patients, you want to monitor their hematocrit, white blood cell count, platelet count, liver enzymes, coagulation factors, and monitor for infection, bleeding, jaundice, nausea, vomiting, abdominal pain, hematuria, and hair loss. You're going to administer prescribed oral antifungal agents. You're going to reduce the dose as prescribed, and they usually base that on lab results. You're going to encourage increased fluid intake, especially of water. Your corticosteroids, prednisone, suppresses that inflammatory response, prevents proliferation of TC, cytotoxic lymphocytes. For those, monitor daily weight, blood glucose, wound healing, monitor for blood and stool, emphasis complaints of acid indigestion, esophageal or gastric burning. Any changes in muscle strength, you're going to encourage low sodium intake, low fat, low cholesterol diet, especially in the presence of someone with high serum cholesterol levels. Administer antacids, H2 receptor blockers as prescribed. They need to take this with food to hopefully prevent or decrease gastric irritation. They may or may not need an oral antifungal agent. You're going to teach the patient that they need to be controlling intake to help maintain that ideal weight. Remember, prednisone can really stimulate the appetite. Going to need consistent exercise to counteract the muscle weakness, hyperglycemic effect of corticosteroids can have on the patient, and the patient needs to avoid skin trauma and hopefully avoid the use of adhesive tapes. So unfortunately, rejection can occur, and even if the patient does everything correct, even though the match had a high percentage, they can still have rejection. Now, there are different types of rejection, and we can compare these. You've got hyperacute, acute, and chronic post-transplant rejection. So hyperacute rejection occurs within 48 hours after surgery, whereas acute rejection is 1 week to 2 years. It's usually most common in that first 2 weeks. And then chronic rejection, that occurs gradually during a period of months to years. In hyperacute rejection, your clinical manifestations would be increased temperature, increased blood pressure, and pain at the transplant site. For acute rejection, you're going to notice oliguria or anuria, especially if they were oliguric or anuric pre-transplant. They'll have a temperature over 100 degrees Fahrenheit. They'll have an increased blood pressure, enlarged tender kidney, lethargy, elevated serum creatinine, BUN, potassium levels, and they will be retaining fluid, and that's in that acute rejection. Chronic rejection, they'll have a gradual increase in the BUN and serum creatinine levels as that kidney quits working over time. They'll have an increase in fluid retention. They'll have changes in their serum electrolyte levels. They'll have fatigue. Now, the treatment for hyperacute rejection would be immediate removal of that transplanted kidney. In acute rejection, you're going to increase, they'll have their dose of immunosuppressive drugs will be increased and monitored closely. And then with chronic rejection, it'll be conservative management until dialysis is actually required again.